Good afternoon, everybody. Today we have assembled on a very auspicious day, that is Physicians' Day celebrations on 23rd December 2021. So we are really very glad enough to arrange this program in an hybrid mode. So I am thankful to all the participants and learned delegates, both offline and online, for making some time off for this schedule. Now, in our Physicians' Day celebration, we are starting with 2 academic programs. Then we will pass on to our main program, that is Esteemed Physicians Celebration. So with this short note, I take permissions from chairpersons, Dr. H.S. Pathak, to start the program. So today, the first program, that is an academic discussion, that is PPIs, that is proton pump inhibitors, more heartburn, less relief. And this session will be chaired by Professor Partho Sarkar, Senior Professor of National Medical College, Department of Medicines, and Dr. Ananda Bagchi, Senior Consultant Physicians of North Kolkata. May I request Professor Partho Sarkar and Dr. Ananda Bagchi to come over the podium and start the proceeding. Dr. Partho Sarkar, please, and Dr. Ananda Bagchi, please.
So, with permission of the Chairman and Secretary of West Bengal API branch, API chapter, so our academic program on this Physicians' Day will start now. I will request Dr. Sanjay Banerjee. His talk is on PPIs, more heartburn and less relief. Very talked about molecule has got very less side effects, though sometimes it can occur after prolonged use, rebound phenomenon. So we'll hear from him about the PPI, less relief, but more heartburn. So I will request Dr. Sanjay Banerjee to start his deliberation.
Thank you, Chairperson, sir, for nice introduction. And with your permission, I have changed the heading a little bit because we all know this is a pharmaceutical sponsored program, but for the sake of discussion among physicians, I think more reliable and acceptable topic would be treating GERD, more heartburn than relief. So this is the prevalence of GERD, gastroesophageal reflux disease. So we are dealing with a disease which is highly prevalent and it spares no continent and no defined group of population. The Indian prevalence of GERD is somewhere between 10 to 30% with an average of around 15 to 20%, and India is in intermediate zone for GERD. And the Indian prevalence is significantly higher than the global prevalence. Okay, so this is the Indian consensus on gastroesophageal reflux disease in adults in 2019. The cohort studies has reported a higher prevalence, and dietary factor in India associated with GERD are spices and non-vegetarian food. Whereas Helicobacter pylori infection gives some protection against GERD, untreated GERD leads to reduced quality of life, impairment of activities of daily living, and in some cases mortality with surgical misadventure or progression to lower esophageal adenocarcinoma. We all know the cardinal symptoms of gastroesophageal reflux disease is heartburn and regurgitation, and the mere presence of symptoms justify to diagnose GERD and treat the patient empirically with acid-suppressing medications. However, there are a variety of other symptoms, including some extraesophageal symptoms, which are often experienced by people at extreme stage of life who often have a severe disease and milder or atypical symptoms. The two main facets of GERD management are dietary lifestyle modification and acid suppressive medications, what we call as anti-secretory. And amongst the widely available anti-secretaries, different meta-analysis has shown that PPIs score over H2 receptor antagonist in terms of overall healing, symptom-free proportion, and symptom relief rate. However, there are challenges faced by physicians and gastroenterologists in the management of GERD. There are 4 different types of challenge from 4 different perspectives. There are inconsistent benefit from lifestyle modification. And though we often provide our patients with a laundry list of diets and lifestyle changes, in practical intervention studies, and this is a very beautiful summary of all the studies published in 2006 in archives, that only 2 intervention measures like weight loss in those with truncal obesity and elevation of the head end of bed at night, these are the 2 only things. These are the 2 things which can only favorably modify the course or symptoms of gastroesophageal reflux disease, and restricting so many foods on intervention studies yielded a negative result. Second point is non-compliance with PPI, and there are many studies, particularly one by most representative, most consistent by Hasim El Serag, incorporating a large number of both erosive and Barrett's esophagus, that has shown that compliance rate is near about 48.5%. That is approximately 50% of the patients on the long run are non-compliant on PPI. And there are many factors which they have elaborated in their meta-analysis. PPIs are till date costly medicine when you compared with antacids and H2 receptor antagonist. And lack of awareness. There is widespread lack of awareness regarding the need for long-term PPI therapy amongst the physicians and also patients. And there is the inevitable consequences of fear of adverse events to a prolonged medication. The commonest adverse effects even the general people know are about NSAIDs and PPIs, because worldwide they are the most commonly prescribed drugs and they are freely available over the counter. And this fear of adverse events often stems out from the inadequate relationship between patient and physicians, and there is easier availability of drugs like liquid antacids and even in the grocery shop. That makes all these things more difficult and push patients to non-compliance. Fear of adverse events can have negative unintended consequences in the long term. And over the last a decade or so, there are many studies highlighting different side effects of PPI. So a large body of evidence emerged that PPIs are not that safe, what we previously believed to be. Unfortunately, most of these are observational studies, and perhaps there is no organ in the body where the effect of long-term misuse of PPI will not cause any affection. The day we all jumped on our feet in 2006 when we came to know that long-term use of PPI increases the risk of fragility fracture. Long-term PPI increases the risk of myocardial infarction in elderly, and the death knell by studies like this, that the risk of death or risk of all-cause mortality increases significantly when people use PPI for the long run. Let us dissect a few of the important studies which are of relevance to the practicing physician. The studies which have elaborated the role of and proved the role of long-term PPI and increased risk of fragility fracture, particularly hip fracture, most of these are observational studies, and there are only 2 meta-analyses incorporating only and exclusively the observational studies. There is no prospective study done till date on this issue. So in 2010, based on this observational and one of the meta-analysis, the US FDA recommended that there should be a black box warning about the risk of bone fracture in long-term use of PPI, and the same US FDA just 1 year later retracted their previous notice, and they have suggested that routine assessment of bone mineral BMD is not recommended in patients who are receiving PPI long run. And if this is one of the newspaper report from Times of India in 2019, and see if this message goes to the common people, what will be their reaction? Antacids will cause kidney damage. A normal person will interpret this type of news item like this. There are case reports and large series suggesting that acute interstitial nephritis is an idiosyncratic reaction that can occur to any medications. Till that, there are only nearly 60 reported cases of acute interstitial nephritis with the usage of PPI. However, one of the things which we are mostly concerned about the risk of incipient chronic kidney disease, end-stage renal disease, and the need for kidney transplantation or maintenance hemodialysis. Two studies, one is ERIC, that is atherosclerosis risk in community, which was primarily intended to identify the risk of atherosclerosis in hospital discharge patient in several collaborative healthcare system in America. As a corollary, identified that PPI use compared to H2 receptor antagonist is increased with increased risk of progression of chronic kidney disease. And this was further supported by Jensinger cohort. And there are many other studies, including some of the Stockholm studies and Veterans Affairs from USA, all conclusively suggesting the notion that long-term use of PPI compared to H2 receptor antagonist is associated with increased risk of kidney damage. And there are several postulated mechanisms to account for that. However, these are observational cohort, and this is mostly extracted as an administrative data. And administrative data, I am sorry to say, are usually projected to please the masters in power, and USA is no exception, because there are many confounders. Like most of these patients were above 65 years of age, had hypertension, diabetes, long-term or intermediate use of NSAIDs or many other medications, which might have confounded the ultimate outcome of progression or incipient chronic kidney disease. And there is a concern even among cardiologists about the long-term PPI and the antiplatelet agents, because there are many studies showing that almost all the PPIs, to be very particular, omeprazole interferes with metabolism of clopidogrel, but prospective studies has refuted the claim. Even amongst omeprazole and clopidogrel, there is no significant difference in the clinical cardiovascular outcome. And this is a study that came in 2019 in gastroenterology, showing that PPIs, both with antiplatelet and antithrombotic agents, they are safe and they do not alter the cardiovascular outcome. So there is a false alarm and the risk and the chance of pseudo epidemics, because quality of evidence is low to very low, association is very weak, and there is always a chance for residual bias because not all confounding factors are known or even recorded. And what we are doing with PPI is actually we are doing medical antrectomy. Long-term use of PPI is medical antrectomy. Antrectomy and vagotomy was quite common 3 or 4 decades back. How many patients of antrectomy and vagotomy or even pernicious anemia, apart from B12, iron and other micronutrients, how many of these patients have developed bone risk, bone fracture risk, kidney disease or interference with the antiplatelets? So compliance can be improved by superiority of establishing that PPIs are superior, perhaps the supreme drugs in this therapeutic basket, proper patient education awareness, and a good doctor-patient relationship. There is this group of patients who do not respond to PPI. A reasonable estimate is 25 to 30%, because not all are candidates for ARS, that is anti-reflux surgery. Hiatus hernia or incompetence of lower sphincter will go for surgery. 2/3 will respond to PPI. And what will happen to the remaining 1/3? Double dose PPI, subjecting them to many investigations, including upper GI endoscopy, impedance, esophageal manometry, and all this gives more heartburn than relief to the doctor, because the number is not insignificant. It's 25 to 30%. And there are other areas in the spectrum of the gastroesophageal reflux disease, like non-acid bile or volume reflux, like reflux hypersensitivity, like functional dyspepsia, because their pathogenesis are different. So clubbing all non-responders to the non-responder, or considering that PPI refractory is 1/3, is perhaps an overestimation, because reflux hypersensitivity and functional dyspepsia will respond only to antipsychotic and antidepressant medications. And volume reflux, as is expected, will not respond to acid suppression because there is no acid. It is bile, or it is the total volume of the gastric content that constitutes the refluxant. So failure of reflux inhibitor is particularly a wrong choice of patient, because all patients cannot be included as reflux, and this cannot be extrapolated that they are not responding to PPI, because different patient needs different treatment, and those who are with non-acid reflux perhaps will respond better to surgical, like magnetic sphincter augmentation, or this is an electrode like what is done with pacemaker, or with endoscopic therapy like ablation of the lower esophageal sphincter, or fundoplication, or anti-reflux mucosectomy. I have personal experience of doing the anti-reflux mucosectomy, but results are not very gratifying. And most of the institutes don't have the technical expertise to perform most of the investigations. And a recent meta-analysis in 2021 identified that none is superior to PPI. Finally, coming to the last point of nocturnal acid breakthrough, it's a universal phenomenon that occurs each and every person. But this defined as presence of intragastric pH less than 4 during overnight period, and that should last for at least 1 hour. The duration is also important, not only the intragastric pH less than 4. This is a normal phenomenon, occurs in normal persons. Even if perhaps most of the GERD this also occurs, but it has huge importance in cases of complicated GERD, Barrett's esophagus, or who have impaired clearance of the acid, because that acid will cause morning laryngeal edema, throat uneasiness, or other cough or other symptoms. Even with PPI 91%, even with double dose PPI 82%, and even with thrice dose PPI 81% will still experience nocturnal acid breakthrough. And even if you add H2 receptor antagonist, which is done by some physicians to control nocturnal acid breakthrough, studies have shown that up to 60% may still experience nocturnal acid breakthrough. So we are left with very few options. Recently, there is a modified release dexlansoprazole. Recently, there is a delayed release ariprazole, though this is not approved by US FDA. And recently, there is a dual delayed release pantoprazole, where 30% of the drug is released in proximal part and 70% in the distal part. Depending on the pH, the coat dissolves. The final question is, what is the best PPI? Because I often face these questions by medical students. That the diplomatic answer would be the best PPI is yet to be discovered, but that will not settle the purpose of your learning. The base, all the PPIs to us, to physicians, to gastroenterologists are same. But is it really same? There are many PPIs. Almost all the PPIs are metabolized by cyclochrome system, except one which undergoes non-enzymatic. And nowadays, because with increasing age of the population, many of your patients are getting multiple drugs. So always we have to identify a drug which has minimum interaction, which has more prolonged action, single dose is sufficient, which has rapid onset of action because of so busy lifestyle, and drug that will undergo enzymatic conversion and will produce least drug-drug interaction. What is the future of GERD treatment? Because this is also a headache for the future generation. The era of H2RA is over. We are at the fag end of PPI, perhaps because we have overused PPI. And the future is PCABs, that is potassium competitive acid blockers. They will achieve the steady state concentration even with the first dose, unlike PPI, which takes at least 5 days. And they are much better, both in terms of healing both all grades of esophagitis as well as symptom relief in patients with GERD compared to PPI. Thank you very much.
So thank you, Dr. Banerjee, for your excellent deliberation. And the subject is open. I will invite 1 or 2 questions or comments, especially from the juniors. If there is any comment or questions.
I have one question. In case of GERD, say laryngopharyngeal reflux is not that uncommon, and it's difficult. So how do you manage? What is your
laryngopharyngeal reflux is one of the extraesophageal symptoms of GERD. 20% of all GERD present with extraesophageal and majority with laryngopharyngeal. Laryngopharyngeal is usually identified our ENT colleagues by showing majority of cases an erythema of the posterior fauces. There may be vallecula or laryngeal inlet edema or small erosions. Most of the societies are non-committal about the exact guidelines of managing laryngopharyngeal reflux. They should be managed with PPI. Prokinetic drugs have no role, neither is a combination of PPI or prokinetics. But in most of the cases, like asthma as well, the first 3 months PPI need to be given in double dosage. It's 1 morning dose and 1 evening dose, and then we have to continue for long. Particularly GERD is a long-term disease.
Sanjay, do sodium alginate has got any role in this management?
Sodium alginate is surface tension. This will precipitate acid. This will float on the surface of the acid. This will prevent the acid to come to the esophagus. But sodium alginate is good for symptom relief. I don't think it cannot modify the course of the disease. Neither can prevent the future complications.
Laryngopharyngeal.
In 2021, people still use antacid because antacids are very good for symptom relief and antacids are very safe in pregnancy and chronic kidney disease, where most of the drugs are not safe. And apart from symptom relief and apart from for those two indications where you cannot write other medicines, I don't think antacids are not going to alter the course of the disease. Prolonged use of PPI in GERD can prevent Barrett's esophagus and esophageal adenocarcinoma. That is the disease modifying role of PPI, which is perhaps not produced by any other drug used in gastroesophageal reflux.
So thank you. Dr. Shivendu Ghosh, you want to add?
One comment is that not only the newspaper, we are ending with the newspaper. In fact, some of the naturopathies they are using it today or yesterday morning. We had got this thing that patient. I mean, they have advertised that probably PPI is doing so much harm to the human being that everyone should go to the naturopathy rather than of going for the your PPIs or other allopathic medicine. This is my one comment. Second, some of the people are very used with the activities which
So Dr. Ghosh, be short because we have got
30 seconds. I think by 30 seconds I'll leave. So what is the advantage of decreasing the namaz, which is particularly those who do 5 walks like this? So does it decrease really the incidence of gastroesophageal reflux in a persons who are daily use 5 waqt namaz, that is around 150 minutes even. Those who are very religious to some. Do you have any idea?
I have no idea how namaz is going to, I have no idea how namaz is going to affect it. Any form of breathing exercises can improve your diaphragmatic contractility and prevent reflux. But I think the posture assumed during namaz will further aggravate reflux. If a patient is already suffering from reflux, once you give the head down, that will further aggravate symptoms of reflux. Those who are already suffering from reflux.
So thank you very much, Sanjay. I, on behalf of my co-chair, Professor Partha Sarkar, conclude the session.
Now we pass on to the second academic session. Now there would be some important case discussion. So if time permits, Dr. Tapos Bandyopadhyay will go for 2 cases, otherwise 1 cases, because so many central dignitaries will be joining online at 1 p.m. sharp. So for this session, I would like to call upon Dr. H.S. Pathak and Dr. Udas Chandra Ghosh for, please come on the dais. Dr. Udas Chandra Ghosh and Dr. H.S. Pathak, please start the proceeding without any further delay.
Good afternoon. This will be another very interesting case presentation, a case of curious pain abdomen. I invite Dr. Tapos Bandyopadhyay on the dais, and I request my co-chairperson, Professor Udas Ghosh, to introduce him and also the subject.
Dr. Tapos Bandyopadhyay is a very good clinician, and actually he is attached with a medical super specialty hospital, Kolkata, as a physician there. And not only that, he is also treasurer of our branch, chapter of API West Bengal, and he is also a good worker of API and very energetic physician. Tapos, please start.
Thank you, chairpersons, and all the dignitaries present here. Without wasting any time, I am present. Actually, I have 2 cases, one very rare and another not so uncommon. So the rare case first. If time permits, I will present 2 cases, otherwise this one. So this is a 57-year-old gentleman presented to our institute with a history of bilateral flank pain since morning. The pain was constant in nature and associated with nausea and vomiting. He had no history of dysuria, hematuria, but there was history of a low-grade fever. Sorry for the The blood pressure at the time of presentation was 180 by 110, and the heart there was tachycardia. His abdomen was soft, non-tender, and not distended. Bowel sounds were normal. The patient carried a diagnosis of hypertension for say, 10 years, dyslipidemia, Graves' disease, and atrial fibrillation with moderate ventricular rate, and he was on long-standing medication for the same. He had also cardiomyopathy with LV dysfunction, ejection fraction being 40 to 45%. The patient was on appropriate medication for the same ailments, including anticoagulation. His present concern was worsening abdominal pain associated with nausea and vomiting for the last 12 hours. Significant past medical history includes multiple episodes of cardioversion in the past for a rapid ventricular rate due to atrial fibrillation, and had radiofrequency ablation 1 week earlier to presentation. On arrival at the emergency department, his blood pressure was already mentioned 180 by 110, and he rated his abdominal and flank pain 7 out of 10 in a scale of 0 to 10, where 10 is the most severe. He denied similar type of pain in the past. He also had denied any history of renal colic or prior surgery. He had no history of travel or any high-risk sexual behavior or intake of any other medication. On investigation, his serum creatinine level baseline rose to 1.8 from 9. He had normal leukocyte count, normal results for coagulation profile, with urinalysis being non-contributory. Serology for vasculitis was negative, and CRP was also normal. Treatment history, he received pain relief medication in the form of opioids and antihypertensive. So at this stage, the diagnosis was probably dealing with urolithiasis.
Just 1 minute. You asked
Yes.
the audience, is there
Any
any suggestion
guess?
for the postgraduates?
Any guess?
Any guess?
The patient presented with pain abdomen with nausea, vomiting for the last 12 hours. He is a known case of hypertension, Graves' disease, and was on medication. He had also cardiomyopathy with LV dysfunction and atrial fibrillation, for which he was receiving regular anticoagulation. So, what is the diagnosis? Okay, so mesenteric ischemia is one definitely. Any other?
Any other suggestion?
Because already I have mentioned that is not that common. It's a rare case. Maybe you have seen in a lifetime or may not. Because when I asked
Clue for
most of the
hypertension.
radiologists and the clinicians that have you made ever this type of diagnosis, they said no. Even the radiologist, but the diagnosis was made. So may I proceed further?
Any other clue for hypertension?
The patient is hypertensive. Yes,
Yeah.
that is the
180
point.
by 110.
Accelerated hypertension. And that will clinch the diagnosis. Unless and until you have the diagnosis on the back of your mind, you can't. So differential diagnosis, what are the differential diagnoses? Pheochromocytoma, yes, but he had no history of similar type of episodes which occur in pheochromocytoma. The episodic.
Okay, let's proceed.
So let us proceed because we don't have much time. So plain X-ray of the KOB initially we did, it was normal. Ultrasonography and non-contrast CT scan of the KOB showed no evidence of calculus or hydronephrosis. There were ill-defined echogenic areas found in both the lower poles of the kidney, suggestive of possible pyelonephritis subjected to laboratory corroboration. However, except slightly raised serum creatinine, everything was normal. Urine examination non-contributory, which negates the diagnosis of pyelonephritis. So, patient was again referred to the radiology department, suspecting that something is wrong from the clinician or the radiological point of view. And this time evidence of intrarenal perfusion defect suggestive of infarction was noted on colored Doppler. But there was no evidence of venous thrombosis. However, the full length, when they trace the full length of the renal arteries on both sides, it's not seen, could not be seen, and pointed towards vascular etiology. CT scan of the abdomen showed bilateral renal and right external iliac artery dissection with multiple bilateral renal infarct. Given the recent history of intravenous manipulation in the form of radiofrequency ablation, it was the diagnosis of intervention-related dissection was entertained, but because of discontinuous nature and bilateral involvement, which is very, very uncommon in catheter-related situation, it was negated, and subsequently we ruled out that part. So this is the kidney showing infarction. This is the one side, but actually the patient had both-sided renal artery dissection with thrombosis, with false lumen, and there is partial both kidney infarct. This is the intimal flap in the dissection. Renal angiogram was definitely carried out on 64 slice CT scan and showed intimal flap in main renal arteries with double lumen suggestive of bilateral renal artery dissection. There was evidence of non-enhancing wedge-shaped areas in lower poles and right mid-pole suggestive of infarction. And in absence of other possible cause of dissection with age, male sex, which is actually the corroboration, and uncontrolled hypertension, spontaneous dissection was diagnosed. During the remainder of the ICU stay and hospital stay, the patient was stable, recovered without any recurrence of pain abdomen, labile hypertension, or worsening of renal function. So, spontaneous renal artery dissection is a rare but important cause of flank pain, renovascular hypertension, and clinician must be mindful of it as a differential diagnosis while dealing with such type of cases. It may be the etiology as well as the cause of uncontrolled hypertension. Sustained elevated hypertension may contribute to arterial dissection by atherosclerosis or medial degeneration. Depending on severity, extent, and main branch versus the branch arteries, spontaneous renal artery dissection may cause ischemia and varying degree and renal mediated hypertension. Renal artery dissection, though increasingly recognized with the advent of radiology, is still very, very uncommon. Cases of bilateral renal artery dissection is even rarer and reported in limited series. Renal artery dissection can be acute and chronic. These are the acute causes, iatrogenic, spontaneous, or can be agonal due to some disease like sepsis. The reason is abnormality in the vasa vasorum and dysplasia leading to the spontaneous bleeding. That is the proposed cause. Association has been made with some connective tissue disorder, fibromuscular dysplasia, Marfan syndrome, like this. Case reports after cocaine abuse and extra shockwave lithotripsy were reported. Sometimes can be the result of unusual physical exercise that may lead to traction of the renal artery. That again can lead to rupture of the vasa vasorum. Most patients are male and with a ratio of 4:1, maybe even up to 8:1 in some series in their fourth or fifth decade. No predilection for any either side of the kidney, right or left, may be accompanied by dissection of other peripheral arteries. Diagnosis must be made at earliest to increase the chance of revascularization and recovery. Clinical features include minimal to life-threatening hypertension and or renal failure. The most common symptom is pain and the more abdomen, and the most common sign is hypertension. It simulates urolithiasis and pyelonephritis. Angiography is the gold standard of diagnosis. CT angio is non-invasive, easily available, feasible, and better choice than conventional or MR angio. Dissection and thrombosis. Sometimes you need to differentiate between dissection and emboli. On angio, dissection appears as a linear filling defect in the lumen of artery or as a uniform narrowing due to non-filling of false lumen, whereas emboli display a meniscus-like crossing the width of the artery. In our case, Doppler USG fails to demonstrate internal flap, but diagnosis of renal infarction was facilitated by color Doppler, which ultimately demands detailed evaluation of the renal artery vasculature by CT angio. Thus, it proves the roadmap to the diagnosis. Management is aimed at controlling symptom, stabilizing blood pressure, limiting influx size, and preventing recurrence. Treatment options include observation, medical management with anticoagulation, control of hypertension, and close follow-up. Surgical intervention are reserved for worsening and renal function when medical therapy has failed. Endovascular intervention, that is stenting or revascularization, required if repeated angio shows unstable lesion or hypertension uncontrollable. It is associated with significant morbidity. A high level of awareness is needed for the diagnosis. Angioplasty is favorable to surgery as a less invasive, less expensive, and associated lower mortality. There are case reports of spontaneous renal artery dissection leading to spontaneous resolution. This is due to re-entry of the false lumen back to the true lumen and or complete obliteration of the dissected segment by thrombosis and organization. Rarely, dissection can lead to arterial rupture. The main cause of mortality is renal failure. Chance of fatality increased by lateral lesion. So to conclude, spontaneous renal artery dissection is a rare and important cause of flank pain and presents a diagnostic and therapeutic challenge. Diagnosis advocated when renal crisis is not associated with urolithiasis or hypertension is present. Doppler ESG has poor sensitivity but provide roadmap. CT angio is the gold standard. May I start the second case? Okay.
Dr. Bandhavadhyay, since we have some time, we can continue
Thank you, sir.
with your second case.
Thank you, sir. If time permits, we can take questions at the end of my second case, if any. So this is my second case. This is again the patient presented to the emergency department with history of pain abdomen and nausea and vomiting. Actually, the patient presented to the emergency department with some mental obstination, confusion, and later on it was found to be there is some hyponatremia. The next day, so this is the case. 48-year-old female presented to the emergency department for dysmorphic mood. She was admitted to the medical service for evaluation and subsequently found to have severe hyponatremia, 122. Her past medical history was notable for fibromyalgia and she had mild hypertension also. She reported alcohol intake with social occasion only, with abstinence for the last 4 weeks. She denied any history of diabetes, binge drinking, any offending drug, trauma, or any procedure recently. She is postmenopausal. Family history was not significant except diabetes and hypertension. On the day of admission, the patient experienced abdominal discomfort that worsened alongside a low-grade fever of 100 to 101 degree Fahrenheit. Her clinical picture began to deteriorate on the day 2 of admission with the pulse rate of tachycardia and hypotension. Physical examination was notable for some tenderness in the epigastrium without any distension organomegaly or rigidity. Laboratory evaluation shows mild leukocytosis, mild anemia, hyponatremia, and elevated serum amylase level and lipase level. Lipase level was 400, it's almost 10 times normal. And the glucose level was, random glucose was at the emergency was 197. The most alarming lab finding was a severe elevation of the triglyceride to the tune of more than 8,000. Liver biochemistry was notable for hyperbilirubinemia, mild hyperbilirubinemia, and raised serum transferase to the tune of 4 to 5 times. The ALT was twice actually, and there was some elevation of the alkaline phosphatase. So abdominal ESG was done. It was normal. Gallbladder and liver with normal intra and extrahepatic bile ducts. CT scan of the abdomen and pelvis showed hypodense lesion in the pancreas surrounded by moderate amount of peripancreatic fluid suggestive of pancreatitis. Ranson score calculated at that time was mild actually. So this is the peripancreatic fluid suggestive of pancreatitis. The initial management include aggressive in the emergency department. The patient was shifted to the ICU. The next day, initial management included aggressive intravenous rehydration therapy with normal saline antiemetics and pain relieving medication in the form of opioids. Patient was urgently transferred to the intensive care unit for supportive care and close monitoring. The patient had a persistent low-grade fever, tachycardia, and raised serum lactate level. Blood culture was done, and carbapenem started empirically in this case. We started infusion of insulin at the rate of 1 to 2 units per kg per day with 5% dextrose solution. Her blood glucose level came down from blood glucose at that time was 180 to 210 and never developed hypoglycemia during the course of the illness. The decision was made to initiate plasmapheresis, but refrained from it as the patient improved significantly with insulin infusion and supportive care. There was a fall of triglyceride to the tune of 5,000 on day 2, day 3, and by day 4 it was almost 2,000. But subsequently, next 2 days, there was the reduction was very marginal in the triglyceride level, and plasmapheresis was contemplated for 2 sessions, and triglyceride level came down to less than 500. The patient was nil per mouth initially, but from day 4 of hospitalization began to tolerate oral fluids. Empirical antibiotics stopped due to the negative culture and clinical improvement. Our total count came down to normal. Renal function was normal, C-reactive protein, triglyceride, everything was satisfactory. The patient was shifted to the intensive care unit, from the intensive care unit to the ward, and on day 7 without any further complications. She was discharged home subsequently with long-term fenofibrate therapy. She was counseled for to continue fenofibrate indefinitely in order to prevent future recurrence. So acute pancreatitis following hypertriglyceridemia is clinically similar to pancreatitis from other causes and sometimes life-threatening unless timely intervened. Hypertriglycemia is the third leading cause of acute pancreatitis after gallbladder stone and alcohol. It is diagnosed from triglyceride level of more than 1,000 or lipemic serum and 2 of the following: abdominal pain, elevated serum pancreatic enzymes, and radiographic features of acute pancreatitis in absence of other causes like gallstone. Serum amylase level may be falsely low with hypertriglyceridemia because the method we actually follow cannot detect the plasma triglyceride level. So lipase level should be used instead. Hypertriglyceridemia causing pancreatitis should be treated like other causes of pancreatitis. Prophylactic enteral feeding is associated with favorable outcome, reduced mortality, fewer infection. So hypertriglyceridemia causing pancreatitis should be treated like other causes of pancreatitis. Prophylactic enteral feeding is associated with favorable outcome, reduced mortality, fewer infectious complications, less organ dysfunction, and surgical intervention. It should be aggressively treated to reduce the triglyceride level below 500. So intensivist caring for the patient should be aware of severe complication of pancreatitis, including abdominal compartment syndrome with aggressively, because of the aggressive nature of treatment, resuscitating the patients, gastrointestinal hemorrhage, gastric varices, and other complications like sepsis, ARDS, and necrosis. Hypertriglyceridemia is defined by fasting triglyceride of more than 150, and this is the mild, moderate, severe, and very severe criteria according to the Endocrine Society of America. Hypertriglyceridemia is considered a significant risk factor for acute pancreatitis with triglyceride level more than 1,000. So, how to prevent? So, hypertriglyceridemia-induced pancreatitis causes 1 out of 1 to 14% of all cases of acute pancreatitis. The risk increases proportionately with higher level of triglyceride. Risk is approximately 5% with triglyceride more than 1,000 and 20% when the triglyceride is more than 2,000. Alcohol increases the serum triglyceride level in a dose-dependent manner. The hypertriglyceridemia-induced acute pancreatitis is usually due to the not due to the triglyceride itself, is most commonly occurs in patient with prior lipid disorder and precipitated by some alcohol, intake of alcohol, diabetes, drugs. Genetic factors determine more than 60% variability in serum lipids, such as patients with type 1, 3, 4, or 5 hypolipoproteinemia. And the secondary causes we know is diabetes, obesity, alcohol, uremia, pregnancy, hypothyroid, few drugs like tamoxifen, antiretroviral drugs. It is the breakdown of the triglyceride that lead to the toxic free fatty acid by pancreatic lipase that is responsible for lipotoxicity. Most patients present in the fifth decade, fourth or fifth decade of life, but much earlier in those with inherited disorder of lipoprotein and very high triglyceride level. Patients with hypertriglyceridemia tend to have much more severe attacks than who have normal triglyceride. It can alter the routine measurement of serum sodium, as I have already mentioned, amylase and LDL. So it causes pseudohyponatremia. The excess triglyceride in a serum sample can displace water containing sodium and cause pseudohyponatremia. Nephrotoxic drugs should be to prevent. What should be done? Nephrotoxic drugs should be stopped. Intravascular volume and adequate perfusion pressure should be restored at initial resuscitation. Further fluid management to be guided by the urine nitrogen hematocrit along with USG assessment of the intra-IVC and extravascular lung water. Balanced resuscitation with crystalloids may avoid the adverse renal outcome associated with starch solutions and chloride-rich resuscitation fluids. Acute pancreatitis is the potential stimulus for development of ARDS. After the initial resuscitation, fluid administration should be minimized. Supplemental oxygen to be used to maintain the serum saturation more than 94 to 95%. And of course, high flow nasal oxygen is preferable to mechanical ventilation. Now, one thing one should keep in mind that intra-abdominal pressure monitoring is essential because of the aggressive nature of resuscitation of fluid. The intra-abdominal hypertension is expected in 15 to 17%, and in severe disease, 15% even have had compartment syndrome. So, intra-abdominal monitoring acts as a prognostic tool in about the severity of disease. If it is more than 25, has a more than 35% mortality rate. Early intra-abdominal pressure monitoring in the course is indicated to anticipate severity. This is the gradation of intra-abdominal pressure grading. Now, regarding insulin therapy, which we contemplated initially, in the presence of concomitant hyperglycemia, intravenous insulin with or without heparin is considered the first choice. Intravenous insulin, regular insulin, 0.1 to 0.3 unit per kg to start with hourly, and to maintain the blood glucose level, 150 to 200 can be given in normoglycemic patients, but preferably in patients those who are actually diabetic. It activates the lipoprotein lipase and promotes chylomicron degradation. It is safe in patients with hypoglycemia. Intravenous heparin stimulates the lipoprotein lipase, but there is a controversy as there is chance of hemorrhagic pancreatitis. Regarding plasmapheresis, therapeutic plasma exchange should be considered in triglyceride-induced acute pancreatitis when triglyceride is above 1000, that is severe, plus serum lipase level 3 times the upper limit of normal or associated with hypocalcemia, lactic acidosis, signs of organ dysfunction or worsening function. So, and the signs of worsening function are temperature more than 38.5 or less than 35, there is tachycardia, respiratory rate more than 20, or the leukocyte count is more than 12,000 or less than 4,000, or more than 10,000, 10% immature band forms. And the long-term management is very important to prevent the recurrence. Acute pancreatitis in patient with hypertriglyceridemia can be prevented by lowering the triglyceride level to less than 200 milligram per deciliter. Non-pharmacological intervention include weight loss in obese patients. This is very important. Aerobic exercise, avoidance of concentrated sugar, and restriction of the dietary fat. And the pharmacological treatment includes gemfibrozil, omega-3 fatty acids, and fibrate. So thank you very much for the patient hearing.
Dr. Bandyopadhyay can take up a few questions. Any questions or comments?
Comments, maybe
Actually, Shundu, the Professor Sukumar Mukherjee is with us. Give a big clap for him.
Thank you.
Actually, sir, we have discussed two cases. One is another important rare cases, bilateral renal artery dissection.
Spontaneous.
So, Shivenda, if you have any question about the renal artery dissection, and I also asked the sir whether you have any rather opinion and you have
So can I just summarize in 2 lines, the first case, then probably sir will be able to. Actually, the first case is
any experience about the renal artery dissection case in your life?
so we got that. So actually the patient.
So before going to question answer, in our link, central link, it is actually central program of API. We are associated with, Association of Physicians Association of Physicians of India West Bengal chapter is associated with that central link.
Yeah.
And already central has decided to felicitate 2 senior teachers from their end. One is our Professor Sukumar Mukherjee. Another is a Professor Premchand Singh from Imphal, and he has already joined there.
Yes.
Give a big clap for him also.
Yeah, he is coming and going. I'll be coming.
So, দেখানো যাবে কৌশিক?
কোনটা?
এক্ষুনি ছিল গেছে আবার
অ্যাড করছে। না ওরা পিন করে দিলে ওটা দেখতে পারবে। এটা শেয়ার করলে ওটা দেবে। ঠিক আছে।
Sir, open your video. Dr. Singh. Yeah.
Good afternoon.
Good afternoon. Welcome you.
So probably we can go to the next session because we already everybody is
Just
joining.
come to the,
Okay.
inaugurator.
Okay. The first.
So any question,
First
Shivendu?
No, I've got 2-3 things, but isolated renal artery, dissection is
Dissection.
uncommon,
Yes.
but it is a very common part of the abdominal aneurysm and autoarteritis. We have seen lots of cases. If you cannot, because of the what happens, but most of the time arteries are very vulnerable to dissection, fibrosis, rupture. All these things can happen, particularly autoarteritis group. But there are also isolation of both renal artery, very uncommon. First thing. Second is you have started antibiotic imipenem on the day of fourth day of acute pancreatitis. I think this is not a standard practice now.
No, we have stopped on that day 4 actually. Initially the level, there was leukocytosis and the patient was febrile. And so we sent blood culture report. This is the answer of your second question. So when the patient clinically improved, usually do not start, but considering that the patient is having the clinical profile of triglyceride level of 8,000, maybe very severe pancreatitis and leukocytosis along with fever. So we immediately stopped when the patient started to improve on insulin, and actually the blood culture report initially after 72 hours they said that it is negative. So we stopped that. So that is the
third thing is hypertriglyceridemia. What is the status of LDL in this patient? Because whenever there is triglyceride increase, LDL may not remain normal. So we always treat the patient with, particularly those who have got, borderline hypertriglyceridemia and along with LDL. So we always treat with triglyceride drugs, decreasing triglyceride drug, as well as statins. What is the step? Because particularly long term.
Yes.
Because they never come only singly as only your triglyceride.
Actually, we send that patient for genetic testing, whether this is a case of isolated hypertriglyceridemia due to hypolipoproteinemia. And the LDL was not that raised. We did it repeatedly. It was marginally elevated like 130, 140. only, and the triglyceride was to the tune of more than 8,000. So other lipid parameters were not that much remarkable. So
When you're going to do the triglyceride test, because plenty of literature are showing the triglyceride, if you do during acute pancreatitis, you can miss some of the cases of hypertriglyceridemia because they decreases due to the time of acute pancreatitis.
No, so the triglyceride level is dependent on the fasting state.
Right.
With prolonged fasting, triglyceride automatically resolve. No, because I have some experience of treating hypertriglyceridemia
Yes,
induced pancreatitis. I have seen many few cases, 10, 12 cases in my life. This is rare, 5%. Alcohol, diabetes, metabolic syndrome, or maybe drug-induced hypertriglyceridemia, they usually don't present as pancreatitis. It is usually a familial hyperlipoproteinemia with triglyceridemia, either type 2 or type 3. There are 4 types, 5 types maybe. They usually come with acute pancreatitis. Most of the patients what I have seen are young females or young males, either gender can be affected. Problem is that you have access to therapeutic plasma apheresis. Most of the people don't have access to that. So in that emergency setting with a triglyceride level of 7,000, 8,000, patient in critical care with acute pancreatitis and with a aggrieved and anxious patient party, how we are going to treat this case? Because most of us, I believe, we don't have access to therapeutic plasma apheresis. Neither we can transport the patient to your center to have apheresis.
right. But there are case series where
And fibrates are going to act slowly.
yes, definitely. But there are case series where they have treated only with insulin, and the level came down. Maybe the duration taken was longer.
See, what we do, we usually treat them with heparin.
Right.
Heparin is a very good drug to
Right.
bring down triglyceride
Yes,
because
yes.
it activates lipoprotein lipase in the blood vessels.
Right.
That converts triglyceride to fat.
Yes.
Another thing is with prolonged fasting, which most of our patients of acute pancreatitis are on, this triglyceride level will gradually subside.
Thank you very much. Thanks.
I have got a small question.
Yes.
So let's start our next program. Thank you, Tapos,
Thank you, everybody.
and for your nice elaboration on the particularly 2 rare cases.
কিন্তু আমার সাথে নেই কংগ্রেস হয়ে গেছে, ঠিক আছে, এটা কোহোস্ট করো, কমিউনিস্ট আচ্ছা প্রেমচাঁদ সিং কে কোহোস্ট করো, প্রেমচাঁদ সিং করছে কোহোস্ট করো। মঙ্গেশ তিরস্কার, এই মঙ্গেশ জয়েন করে গেছে মনে হচ্ছে। মঙ্গেশ তিরস্কার জয়েন করে গেছে, ওটা পোস্ট করতে পারো। তিরস্কার ওকে লিখে দিয়েছি ম্যাডাম, জয়েন করে গেছে। দাঁড়াও, ডিএমএসে ঢুকছে, ঢুকে যায় সিস্টেমে দেখুন, ডিএমই ঢুকছে, ঢুকে যাচ্ছে। হ্যাঁ তারপর কি আছে, বসে আছে, হয়ে গেছে তো এক্ষুনি ডিএমএসে ঢুকে যাচ্ছে। ঠিক আছে, তোমার কাছে মোবাইল আছে, তাহলে আমি এটা কেটে দিচ্ছি। হ্যাঁ মোবাইল আছে, ওটা থেকে আমি দেখতে পাবো, তাই তো? হ্যাঁ এখানে লিভ করছি। ঢুকে গেছে অনেকক্ষণ, পার্থ ধরকে নিচে পাঠিয়ে দিয়েছি। আপনাদের নিচে আছেন তো?
ডুবে যাচ্ছে একটু।
এটা তো? এটা তো? ঠিক আছে। আমি অন করে রাখছি। ঠিক আছে, অন করে রাখছি। ঠিক আছে, করে রাখছি। এখন হবে, share করে রাখছি।
বুঝতে পারি।
Good afternoon, everybody. I welcome all the delegates and esteemed seniors of API and dignitaries, Vice Chancellor Madam, Director STM Madam, and all my esteemed faculties. So today we are going to celebrate 77th birth anniversary of API, and Professor Kamalesh Tiwari, President API, is connected online. Sir, I welcome you. Dr. Mungesh Tiaskar, our Secretary General of API Headquarters, also connected. I welcome Dr. Mungesh Tiaskar.
Thank you, Dr. Jyoti. Thank you very much.
Thank you. Thank you. I welcome Dr. Premchand Singh from Imphal, who will be the another who will be felicitated by Professor Tiwari, President API, also connected. I welcome sir you.
Thank you, sir. Thank you.
Okay, ডেকে শুরু।
Good afternoon, everybody. So 23rd December is our auspicious day, and every year we do celebrate Physicians' Day on this occasion. And this is going on for decades together. And every year on this occasion, not only the felicitations of senior doctors, esteemed teachers, we also go for various activities. This year also, even in COVID era, we have been able to perform this program on hybrid mode. So at the very outset, I am thankful to all the learned gathering over here, both physically as well as online, for taking some time off to be present here to attend the Physicians' Day ceremony. So on this occasion, it is my proud privilege to call upon on the dais Dr. Shuhrita Madam. And now I call upon Dr. Nandini Chatterjee to call upon the dignitaries on the dais to start the felicitation program.
Good afternoon, everybody. Today we are gathered here to celebrate Physicians' Day. It is the birth anniversary of Association of Physicians of India, and it is celebrated on the 23rd of December, the date on which API was born in 1944. The initial founder members came from all over the country. They were eminent physicians all over India. The first president was Dr. Jivraj Narayan Mehta. And his first presidential oration, interestingly, was published in our very own JIMA, which was published from Kolkata. Now, the purpose of a new association was to uplift medical education, to encourage medical research and publication, and to ensure professionalism and services to humanity. And this tradition is going on through the decades, from the guru to the shishya, and the young, they learn from the experience and wisdom from the seniors. So today, we, on this auspicious day, have gathered to pay our tribute to eminent physicians whose dedicated service to mankind over the years inspires younger generations. So may I call upon this stage Professor H.S. Pathak, Chairman, API West Bengal. Dr. Amal Kumar Banerjee, sir, who is not been able to join us due to some personal affairs. Virtually with us, we have the privilege to be joined by Professor Kamlesh Tiwari, who is the National President, API. Sir.
I'm here.
Ah,
I'm here.
yes, okay, sir. Dr. Mungesh Tiwaskar, Secretary General, API. Sir.
Afternoon. Thank you very much. Namaskar.
Professor Shurita Pal, Madam, our Vice Chancellor, West Bengal University of Health Sciences. Professor Debashish Bhattacharya, Director, Medical Education, Department of Health and Family Welfare, Government of West Bengal. Dr. Ajay Chakraborty, who is on the way, our Director, Health Services. Dr. Rupali De, Director in Charge, School of Tropical Medicine. Madam. And Professor Monju Banerjee, Principal, Medical College, Kolkata. Madam, please join us on the stage. Now I invite Professor H.S. Pathak, sir, to give the welcome address.
Good afternoon. As chairman of API West Bengal chapter, it is my proud privilege to make this welcome address. API values the lifelong academic contribution and medical services to ailing humanity by our senior physicians. Hence, we at API celebrate this day as Physicians' Day. We feel proud and privileged to have amongst us our Vice Chancellor, West Bengal Health University, our Director of Medical Education, our Director of Officiating Director of STM, Professor Monju Banerjee, Principal of Medical College, and other dignitaries like President of API, Dr. Mungesh, Tivaskar, Secretary General of API, who are online. We celebrate this day every year, and this has been, in fact, for this year, there are something new in our curriculum. We have arranged posthumous award and respect to our departed members like Professor Arun Kumar Banerjee and Arun Kumar and Professor Anup Kumar Bhattacharya. I also welcome all the executive members of our branch, all the members of our branch. I also welcome all our junior friends, young PGTs, faculty from medical college, faculty from School of Tropical Medicine in this program. This time also is for the first time that our branch is arranging simultaneous Felicitation program on this day by the API headquarters and also 4 districts, Murshidabad, Siliguri, Malda and Midnapur. And they are also conducting this facilitation program in association with Central API and our API branch. I will fail in my duties if I do not welcome all our members who are online and also offline, because without their presence and encouragement, our program will not be success. Thank you.
Thank you, sir. On account of his busy schedule, I would request Sir, DME Sir, Professor Debashish Bhattacharya, to say a few words.
Good afternoon, and it's really a pleasure for me to be around here. It's nice to see all our seniors in front of the rows, because they all are grand teachers. And quite naturally, I felt overwhelmed seeing them here around. I wish and pray their good health and their solidarity amongst the whole fraternity, which we have been able to achieve to be here around, even fighting COVID. So all of us are here together to celebrate this auspicious occasion, and we are working together, fighting COVID, and will fight it out from this world. I wish and pray to Almighty that the new year of 2022 will be a really good new year for all of us. Thank you. And I am really sorry that I have to move out again, go back to again Shastra Bhavan. Only for this occasion, I have just come to see you and feel myself blessed with your all grand presence. Thank you, sir.
Sir, please take your seat. Just a minute. We will be offering flower bouquets to all the dignitaries, because sir has to go away. Then we'll continue with the program. I would request our national president, Professor Kamlesh Tiwari, to address the gathering.
Thank you, Nandini. Thank you very much. First of all, I would like to thank West Bengal chapter of Association of Physicians of India for organizing this program. Actually, this program is going on in the whole country. Whole country is celebrating this day, Physicians' Day, and West Bengal chapter is one of them. Another thing, this year we have started a new thing from the center to felicitate our senior members. And from this territory, we have selected two persons, Dr. Prem Chand Singh and Dr. Sukumar Mukherjee. And in the evening, we are going to arrange this celebration from 5 to 7 p.m. And I will request you all to join in the national celebration program in the evening. With these words, I will thank you again, West Bengal chapter, for organizing such a nice program and felicitating the senior most physicians. Thank you very much. Thank you.
Thank you very much, sir. Now I'd request our Secretary General API, Dr. Mungesh Tiwashkar, to say a few words.
Good afternoon, everybody. Thank you very much for this beautiful opportunity. I congratulate all of you for being such an innovative branch. And not only that, this is under the guidance of our President, Dr. Kamlesh Tiwari. His leadership has really given this Physicians' Day a different shape altogether. Because this was for the first time ever in the history of API that we have decided to actually honor and respect all those dignitaries, those who have contributed to the physicians academically and as far as the leadership skills as well. I would also put on record the congratulations to Dr. Jyotirmay Paul and the entire West Bengal team for such a lovely program. And as our president has said, that I also would request you all to join us in the evening between 5 to 7 for a countrywide celebration. United, we will stand and celebrate and appreciate all those dignitaries, those who have been really making difference in the lives of all of us. Thank you very much. I wish you all a very happy and a prosperous New Year and a very Merry Christmas. Stay safe, stay happy. Bye-bye. Thank you very much.
Thank you, sir. Now I would like to invite our Vice Chancellor, Professor Shweta Pal, to address this gathering.
Good afternoon, everybody. I'm really honored to be a part of this auspicious occasion today. Before even I begin, I want to say pranam to my teachers. I can see them sitting right in front of me, and really I feel blessed and somewhat embarrassed also to sit in front of them on a chair which is partly ornamental and partly very, very challenging also. So the Association of Physicians of India, they have been doing a marvelous job since 1944. Not only COVID, but we have learned so much from our teachers. It is the legacy of Guru and Shishya Parampara, as Dr. Nandini just mentioned. And this will go on and on, be it in the pre-COVID, COVID, or post-COVID era. We strongly believe in that. And so I wish all the members of API and all associated with API a very, very happy New Year, happy going, and the strive for knowledge and excellence may be kindled in them till eternity. Thank you so much.
Thank you, Madam. Now I will like to call upon Professor Rupali De to share her thoughts on this occasion.
Good afternoon, everybody.
it is a very proud as well as a humbling moment for me to stand again, as Professor Paul said, in front of all the dignitaries and the luminaries and our teachers whom we think of in a godlike manner. So thank you, sir, for coming and embracing the new normal, masked appearance of everybody, but a physical presence all the same. Thank you. On behalf of STM, School of Tropical Medicine, I welcome you all to the Physicians' Day celebration by API West Bengal chapter. Thank you so much. Thank you, ma'am. Now I would like to invite Professor Manju Banerjee to say a few words.
A very good afternoon to all of you. Coming to a program which is celebrating the Physicians' Day by the API West Bengal chapter, I really feel privileged because medicine is not my fraternity. And what happens is whenever I come in presence of teachers like Professor Shukumar Mukherjee, I'm not a student of West Bengal. I feel, I don't know why, I just really feel very blessed that maybe because of my doing a service here in West Bengal medical education, I have been able to come in close contact with legends like Sir. And I'm really sorry, but I don't know the names of the other legendary persons sitting in front of me. So that feel-good feeling is what brought me here today. And Professor Udas Ghosh was insisting on that I should be here for this moment. So I thank you all, and I thank the West Bengal chapter. And in the new normal period with COVID, hoping for the best that 2022 will be a post-COVID era which we'll be facing. We are not very sure about it with the Omicron going on. But let's hope for the best. My sincere regards to all of you, and I hope that this program will be a success. Thank you. Thank you all.
Thank you, Madam. Now we would like to welcome all the dignitaries with flower bouquets, and we also would virtually like to offer flowers to Professor Kamlesh Tiwari and Dr. Mangeshkar, who have joined us online. Professor Shurita Paul. Professor H.S. Pathak. Dr. Rupali De. Professor Manju Banerjee. Now we have the pleasant duty left of lighting the inaugural lamp, and I would like to welcome all the dignitaries on a virtual platform as well as on the dais to come forward, especially the National President API, Professor Kamlesh Tiwari, sir.
Good afternoon, everybody. Now we will start the program for which we are waiting for since 12 noon. At the very outset, I'm really thankful to all the dignitaries over here, as well as online, Dr. Kamlesh Tiwari, President of API, Dr. Mungesh Tiwaskar, Honorary Secretary, API, and respected dignitaries on the dais, that is our Dr. Shuhrita Pal, Madam, BC, University of Health Sciences, DME, Dr. Debashish Bhattacharya, he had to leave the occasion because of his busy schedule. DHS is on the way to come over here. We will invite him whenever, as soon as he reaches here, we will invite him on the dais. Director in charge of STM, Dr. Rupali De. He is also at the present moment MSVP of STM, School of Tropical Medicine, and all other learned gathering present over here, both online and offline. I am really thankful to all of you for making some time off to be present over here in this auspicious occasion, that is Physicians Day celebrations on 23rd of December. And we do celebrate it every year. And here the celebration is unique in various ways. Why unique? Because this is the first time when our central API body has started felicitating our esteemed API members, esteemed distinguished teachers from each zones of India, including the Eastern Zone. And in Eastern Zone, you all know that Professor Sumukumar Mukherjee and Professor Premchand Singh, who was online, is there. And there are other distinguished API members as well as teachers from other zones too. So far, our West Bengal API state chapter is concerned, we all the time, this is the first time for central API body, but we are celebrating our esteemed, distinguished, famous, revered teachers every year on this occasion, on this very particular day. And we feel proud that we have elected some distinguished teachers, but at the same time, we are sorry that we have lost two of our very esteemed faculties who were actively participating in all the activities of API. And probably you all know the name of these two stalwarts of API, West Bengal chapter, that our chairperson has already told. And this is the first time we are celebrating some distinguished teacher posthumously. And it is the brainchild of our chairperson, sir, that is Professor H.S. Pathak, and it has been accepted in EC meeting on 4th of December 2021. So here we are celebrating these two very highly spirited academic and dynamic API distinguished teachers, Professor Arun Kumar Majumdar and Professor Anup Kumar Bhattacharya. So with these few words and introduction note, I will now go to the main program of felicitation of our teachers, and we really feel proud by felicitating this teacher of the teachers on today's occasion. So I, right this moment, request the pleasure of active participations of our EC committees so that our program will be running very smoothly. On the very first occasion, I will request Professor Shivendu Ghosh to come over here and escort Professor Sukumar Mukherjee on the dais. You all know Professor Sukumar Mukherjee. A big round of applause, please. You all know Professor Sukumar Mukherjee is really teacher of the teachers, and we are really feel very proud and honored to felicitate like teacher of this personality. He taught both the undergraduate and postgraduate students, and we used to listen to his lectures amazingly. We remain spellbound whenever he teaches something to us. So I would request Dr. Shivendu Ghosh as well as our VC Madam, Dr. and others also to welcome our sir with a full flower bouquet. Dr. Rupali Madam, Dr. Manjusri Madam, please come and felicitate our teacher of the teachers, that is Professor Sukumar Mukherjee. Please come. And our chairperson also. Please join hand in hand. Please, thank you. As per request of Professor Anil Sarkar, please give a standing ovation আচ্ছা হ্যাঁ বলতে দেবো তো লাস্টে বলবো হ্যাঁ মে আই রিকোয়েস্ট ম্যাডাম প্রফেসর মুখার্জি প্লিজ কাম হিয়ার Thank you, madam, for taking all the trouble to come over here. We are really grateful to you. Now, I would request Dr. Shivendu Ghosh to read out the Manpatra of Professor Sukumar Mukherjee. Please come over here to read out the Manpatra.
So it's very difficult for a person like me to enlighten or say something about, say, very legend in our medical field, nationally and I think internationally famous person. But still, this is a convention, and I am just reading out which has been sent from our central API, and I am grateful to our chairperson, to secretary Jyotirmoy, and all the API member for allowing me for Professor Sukumar Mukherjee. This is the Association of Physicians of India, and this is to certify that Dr. Professor Sukumar Mukherjee, Kolkata, awarded for the outstanding dedication and valuable contribution of leadership and academic services to the Association of Physicians of India. This citation is bestowed in memory of late Professor Dr. Siddharth Ensa on Physicians Day, celebration held on 23rd of December 2021, and is signed by President of API, Dr. Professor Kamalesh Tiwari, and Honorary Secretary General of API, Dr. Mangesh Tivaskar. So with this, may I stop here and handing over this citation to our very respected teacher, to Professor Mukherjee.
না ম্যাডাম আসুন আসুন Professor Sukumar Mukherjee is awarded by our central API member. So I would request Professor Kamalesh Tiwari to say a few words. Hello, is Professor Kamalesh Tiwari online? No. So I would request felicitate our Professor Mukherjee with some our offerings of respect. So I will request all Rupali Madam, Manjushri Madam, as well as our chairpersons and Suhita Madam. So please felicitate our, please give the cap and shawl on his shoulders.
Madhubani Club from Madhubani Club. Please come here.
অনেক লেট হয়ে যাচ্ছে।
সরজিদা রেডি, রেডিটা তো শুনলাম। চলো
আসুন স্যার, প্লিজ বসুন। Professor Dr. Ajay Chakraborty, our respected DHS has joined us, and I request him to be on the dais, and he is already on the dais. And we will have once again photo session with DHS and Professor Mukherjee. Thank you. স্যারকে নিমন্ত্রণ করেছি তো। হ্যাঁ, এইবার স্যার বলুন। ও now our আর 10 মিনিট, 1 মিনিট। Our chairperson sir wants to say a few words about Professor Sukumar Mukherjee. Then I will request Professor Mukherjee to say a few words. First, our chairman sir.
Today, I am completing a full circle. I joined in 1985 in medical college when Professor Mukherjee was head of the Department of Medicine. I joined as clinical tutor. With his inspiration, I took membership of API. After a few years, sir inducted me in a very young age in the executive committee of API, though there were lots of more, Dr. Alokendra Ghosh, Prashant Mukherjee, NB Devnath. We worked as a volunteer in 1989, probably sir, Epicon 2089. And first API West Bengal branch, and a number of letters in his cap. Today, as present chairman of API, I could be associated this Physicians Day program. So it's a complete circle for me. Thank you, sir.
May I request Professor DHS sir, Dr. Ajay Chakraborty to say a few words about our occasions. Then Professor Mukherjee will say a few words. Dr. Ajay Chakraborty sir, please say a few words on this occasion. May I request Shivenduda, may I request you to welcome our sir with a flower bouquet.
Only flower will not help the culture of us to give you some sweets also. So please accept sweet flower.
Thank you, sir. সেদিন বললাম আপনাকে আমি যে আসতে পেরেছি না, তো ব্যস্ততার মধ্যে। Few words for us.
Warm welcome. I am very fortunate to get that invitation and also to able to attend the seminar. because you see there is a lot of work pending in the health department and work is never ending. But recently what happens after a fight with Corona last 2 years, now we are thinking to just continue some other work, the routine work, and also some new ambitions, new things to take into our activities so that we can develop further. But yesterday, 2 Omicron has found positive in Calcutta. They came from abroad, one from Nigeria, another from UK. And this is a starting. This is nothing. This is a starting. We are just waiting for when it will going to start. Omicron is coming, no doubt about it. But we are all relaxing. The total health department, the hospitals, everywhere, it is a low equilibrium state. And everybody is thinking that now that COVID is over, now we'll have to change these things because since long we are talking about the third wave, and third wave we didn't face. So we know that these things will go on like this thing and it will be normalized nowadays. But see, the Omicron, how is coming, nobody we are knowing. But what I anticipate at the end of the February or March, my maximum after end of the February, it will come like a steep spike. A recent calculation just telling, last time you see in the first phase, first wave, the highest peak was 4,100 cases per day, last peak, and that was in Shoshti of Durga Puja 2020, that October. Then there was a low as low as 180, 120 like that. Oh, sorry, 140, around 140. And from that, when it took only 180 after 7-10 days, then we anticipated that something is coming, but nobody could imagine that more than 1,000 cases per day will be possible, because last time it was 4,000 and now it is only 140. So maximum 1,000 cases per day it can go, or maybe in the month of April it will go up to 2,000 per day. That was my anticipation. But see, that time it came to 20,000 per day. 22,000 was the peak during the May. Sorry, what is my time? Just 5 minutes. Sorry, I shouldn't kill time. But thing is that because I want to aware you all physicians here, because this is the challenge you will have to take up. We will definitely give the administrative support, but only the physician will have to take up the challenge of COVID. But this time, what I'm just elaborating with the scenario, nobody could anticipate it, that 20,000, 22,000 per day case we can handle. And this time it is going to be more than that, even maybe 35,000 to 40,000 per day, because the transmissibility is very, very high. The R value is twice or 2.8 times. That means almost 3 times than the previous. So if you go for theoretical, then it will be 60,000 per day. But I am telling you that may not be like that. Maybe we are not able to diagnose that thing, and many of the cases will be asymptomatic, so they will freely move around the community. But the problem is the sheer number will give the pressure that all hospital bed will be occupied, and then the deserving candidates, they may not get the chance to be admitted in the hospital. They may not get the oxygen. Though this time we have just created a lot of oxygen, maybe the oxygen concentrator, many of oxygen devices, so that it can generate the oxygen also. We are not depending on the sole supply of the oxygen cylinder. But still, I am telling you, because of the sheer number, I do not know, because every country, every other country you see in the foreign, they are just facing the really real trouble. So should we think that they have not prepared anything in between? So they have prepared all these things till they have gone to lockdown, and the number of patients are dying, because you see, because though maybe they have been cured, but in the sheer pressure we cannot concentrate, give the full support to the treatment to the patient who deserve it, particularly the older ages. And recently I have seen, you see, only 7 to 10 to 12 patients are dying every day, and it is a total 600 cases per day. But what I have analyzed these things, just there is a shifting of the age. Shifting of the age means the diet patient, their age has shifted above 75. The 60 to 75 age group, the same death rate is around the 40% of the total cohort. So since the beginning, it is same around 40%. But among the 75 age group, it has come from 23 to 38%. The whole cohort, if you see, it is only 23%. But this December only, it has come to 38% of the diet persons are over the age of 75. So the over the age people, they must be taken very, very cautious. And you see, the 2 dose also doesn't protect, previous infection doesn't protect. So this will be a havoc in this time. We all should be prepared. I'm sorry, because I've started with these things, because whatever we are doing, we'll have to keep in mind that impending this third wave that will be the Omicron wave, that we'll have to face, and will be very serious, and we'll have to prepare everybody, the community, our ASHA, the ANM, all these things. So the peripheral, we can just identify the clusters very quickly, and also keep ready for all the hospitals and all our doctors trained for this issue, trained for the critical treatment. All these things should be done very short time, because only 2 months is time now to prepare, and then we'll have to fight that big fight. But fortunately, this fight will last for 1 or 2 months, not more than that, because the steep rise, you see, then ultimately it will hit the very suddenly, but also it will go up suddenly. So I think that should be February to April or May. We'll have to be prepared and we'll have to face a very tough time. That is the thing. But the thing is that the contribution of the API and the contribution of these things during this COVID also, and for the difficult cases of malaria nowadays, emerging diseases, so many things are happening. And we are very fortunate, from the government, and in particular, people in general, they are getting benefit by the way the API is coming forward nowadays, because the API only just confine themselves in the academic thing. They are coming to make this academic into applicable in the society for the benefit of the humanity. And actually the answer exactly, they come up in the right moment with the right direction. So I'll hope definitely API will guide us how to manage the COVID patient, particularly Omicron. Till now, we do not know the treatment, and the very newer molecules are coming regularly. And just last Sunday, we are just having a good discussion among the API that what the molecules will have to use and what is their stage, and then how to tackle this next wave. So I think we'll be really very, very proud to get the opportunity to get the help from the API, and API is wholly dedicated to support the government and to support the people to come in to overcome the distress. So thank you very much for inviting me to this opportunity and this occasion. And definitely I'll just will be always be with you, and also give all the support you need from that part of the government. We'll just extend all the support, but we also want that you guide us regarding this handling the public health emergencies. Thank you. Thank you.
Thank you, sir. API, on behalf of API, I confirm that all the support from the API will to the government of West Bengal, and very soon we are making one conglomeration of the all allied society, API, RSSDI, CSI, and we'll give you later that we all 7 societies together will help government of West Bengal and mankind in controlling any epidemic or endemic.
Thank you, Dr. Ajay Kumar Chakraborty, sir, for your word of caution. And after hearing your word of caution, I have put my mask once again. So at least I have been a little bit more come. Yeah. And second, there is Professor online Professor Kamal Tiwari, our most respected chairpersons of API. Sorry, respected president of API national body. So I would request to say a few words about our felicitations of Professor Sukumar Mukherjee. He has already been felicitated. Due to some technical glitch, I couldn't contact you that time online. So please say a few words about our Professor Sukumar Mukherjee. He has been already felicitated. Then Professor Sukumar Mukherjee will come to the dais. Over to Professor Kamal Tiwari, sir.
Thank you, Dr. Karmakar. Thank you very much. And good afternoon to everybody. First of all, my big pranam to Dr. Sukhbar Mukherjee. He is like our teacher, guardian, mentor, and torchbearer of Association of Physicians of India. My heartfelt pranam goes on his feet. Today, I've got a chance to felicitate him in the West Bengal chapter. Actually, this day we are celebrating on a national level, and this Physicians Day and Felicitation program is dedicated to memory of Dr. Siddharth and Shah. So on this occasion, I would like to felicitate you from West Bengal chapter. Dr. Sukhbar Mukherjee, please, sir.
Thank you, sir, for your words of inspiration. Now, may I call upon Professor Sukumar Mukherjee to say a few words.
Good afternoon, my learned colleagues, students, Vice Chancellor, and Principal Medical College, Moinju. He is not here. I am Ajay Chakraborty, Director of Health Service. It is a privilege to be here, and I take it with great honor. The API Central and API State Baptist has come forward to felicitate on a special occasion the birthday of API. I remember my younger days when I was a student of Professor J.C. Banerjee. J.C. Banerjee was the first API president from West Bengal, followed by Professor Shamul Sen, then followed by me. And we were all students at that time. We were very enthused about the activities of API and heard all about the stories of big guns, right from the Jibraj Mehta to various senior people. And I loved to work. And my first experience in 1989, I was the organizing secretary of the APCON 1089. And it was a great experience for me. I remember event at that time when I was busy. One senior doctor, he is no longer here. He came and he became ill just on the Chaurangi road. He had a cardiac problem. I had to take him to the PSSKM hospital and tried to persuade the doctors to help our very great friend, a very senior API member. Then we sent him home to Bihar. Many events I have, and I have got nostalgia of API activities. And I have seen the ins and outs from the top post of a president, dean, and secretary, organizing secretary, and published many monographs. And that was my craving to be involved with API. And I was actually encouraged by Professor Shamul Sen. And he encouraged me to join API and to do activities. And I see lots of torchbearers of API now. I feel very glad that they are all my students, and I am such pleased for their kind of hospitality, their respect, their love, which is going to stay. And API is a kind of brotherhood. API is a kind of situation where we exchange our knowledge, share the experiences, we help each other. Many events have followed in API activities. And ultimately, API has shown the way. And at that time, at our time, it was only merely 11,000, and it is members. And now it is more than 25,000, 30,000, if I am correct. And only in 89 API, the people attended 1,800. But now it has been enormous. And API has brought out so much of publications, so much across the country for teaching purpose, for educating out of rich centers. And I was a participant of many centers as well at those times, in those days. Because I was president in 1992, when some of them possibly are in the studying in the medical colleges. So obviously, I have got love for API and I have love for the state chapter of API. And at that time, we had the office in Creek Row. We had to operate from there. And I got so much of help from youngsters. And these youngsters have enthused me to go ahead and to at the national level. So that is why we have participated. And West Bengal has made a great impact in the national API. That is another important issue. At least Central API cannot ignore West Bengal branch. And West Bengal is one of the key players in the formulation, progress, and many other activities, not only publishing books, encouraging education, but also helping. And there is a kind of exchange of friendship, an exchange of communication, an exchange of knowledge. Because knowledge is far, far wider. What each man can do that, can share. So obviously, API is our mother association. I remember, though there are many associations in the country, many fragmentation of association happen, but API is the mother association of all physicians. Just RMA is a mother association of all the practitioners of the country. So obviously, we have got many memories, nostalgia, and this case. And that's why I'm particularly indebted those Central API and State West Bengal for their pioneering work in spreading education, recognizing the people. If you recognize the people, it makes you more greater than the people who are recognized. So obviously, this is an important issue to remember. And in our lifetime, we have got many students, and how they go up in the ladder, it is astonishing. And I feel always proud when my students, near and dear ones, are getting key positions in the profession, in the association, in the education, in the research work. So obviously, this is a great occasion I will cherish in my life. And that is what this is the time to remember. So I was just discussing with our Vice Chancellor, who happens to be my student. And she has become Vice. I feel so proud when the student outdrive the teacher. That is a great success of a teacher's life. If you can make your juniors to what remembering, then I think I feel great. It is no question of jealousy, but I feel great. This is the thing which I feel. Manju Banerjee is also principal of medical college. I met her so many times, Murshidabad, Calcutta, everywhere. And so obviously, we are having very, very good number of learned, respected, eminent people in our profession. I think what we need to inculcate the trust of the patient. That is the most important part, because doctor-patient relationship is not very suitable in the current days. We are in many professional organizations, and I find what the people will say about you. People will sometimes adore you. People will sometimes respect you. But love and respect is more important, for which we have to share something, some thoughts, some time for the patient. That's why you can have a better feeling between patient-doctor relationship, which is the key word in clinical practice today. I'm very grateful to State Chapter, Harishankar Pathak, Udas Ghosh, and many others. Mrinal Rai, I can see Shivendu Ghosh, Soumitra Ghosh, and many others. And I find my old friend, Dilip Mujumdar, Ashish Banerjee, these are all my old friends based in different institutions, and they are a great boon to our association. I feel in their very API will be enriched by senior and junior, and good communication, good rapport, good relation, but ultimately love and respect will stay forever. Thank you very much for your kind attention.
Thank you, sir, for your guidance, blessing to API all the time. And we need your guidance and blessings for time to come. So Thank you, sir. Thank you. Thank you, sir. And I need, yeah. Thank you, sir, for coming over here. And we really, you please keep on giving your blessings and your guidance to all API activities. Now we are going for another Central API awardee, that is Dr. Premchand Singh, is stalwart over there from state of Manipur, and I will request Dr. Jyotirmoy Paul to read out his Man Patra.
Good afternoon, everybody. I am very thankful to Professor Kamlesh Tiwari to giving me opportunity to read out Man Patra of person like Professor Premchand Singh. Professor Premchand Singh retired as a professor of medicine of Regional Institute of Medical Science, Imphal. He was MBBS from Rajendra Medical College, Ranchi in 1971. He passed MD from IPGMR, Kolkata in 1976 and joined in Regional Institute of Medical Science, Imphal in 1977 and retired as a professor in 2014. In his career, his academic achievement, we cannot read out. But to mention few, he was a Commonwealth Medical Fellow. He was a Commonwealth Medical Fellow from Sheffield University from 1987 to 88. He was a visiting scholar in Department of Medicine, Royal Hampshire Hospital, University of Sheffield, UK. He was the president of Northeastern Diabetic Society. He was a founder chairman of East Zonal API Committee. He was a founder member of Diabetes in Pregnancy in India. He is a member of American Association of Clinical Endocrinology. He is a life member of API RSSD IMA. He is a past chairman Medical Society of RIMS. He was a past advisor to UPSC. He was a course director in IGNU and past principal investigator of many ICMR projects. He published in his career more than 50 papers in national and international journals and updates. But to say I had opportunity or privilege to work under him when 2013 we formed the East Zonal API Committee. He was the first chairman in 2013 and 14, and I learned so many things from him, particularly how to make the scientific program more acceptable for the postgraduate student and general practitioner rather than the specialist physicians. And second most important thing, I learned how to reach to the grassroots level, keeping aside our confinement mostly in the city area or in the arena of the high-tech medicine. Till now, I remember, sir, your contribution, your teaching, and the way you have showed me us the pathway till we remember and follow. To read out the Man Patra that is given by the API headquarters from Professor Kamlesh Tiwari, President API, and Dr. Mungesh Tiaskar, Secretary General of API. The Association of Physicians of India, this is to certify that Dr. Premchand Singh of Imphal awarded for the outstanding dedication and valuable contribution of leadership and academic services to the Association of Physicians of India. This citation is bestowed in memory of late Professor Dr. Siddharth N. Shah on Physicians' Day celebration held on 23rd December 2021. With this few words, Dr. Kamlesh Tiwari again was disconnected. He has some technical problem in Patna for connection. Again, he is disconnected. With this few words, I request our secretary, Dr. P.S. Karmakar, sir, you virtually hand over Man Patra.
We are really feel honored to felicitate our one of the stalwarts from Manipur State, Professor Premchand Singh sir. So I will request our another stalwart of API West Bengal chapter, Professor D.K. Mojumdar, very dynamic, very active, and all the time he is with us for any activities of API curriculum. So I would request Dr. D.K. Mojumdar, and I will request Dr. Pal as well as Dr. Shivendu Ghosh to help him and to show online all these offerings to our Professor Prem Chand Singh as a token of respect and appreciation to his contributions to our API national body as well as Manipur state chapter. Thank you, sir.
In this particular occasion, like our teacher, Professor Sukumar Mukherjee, the another stalwart, Professor Prem Chand Singh, who have been felicitated today from the center of the API, and both of them, not only in the academic side, but also in the executive work of the API Central, have contributed a lot. And that's the learning thing for junior like us and all the juniors who are present here today. With this word, I like to conclude my talk. Thank you.
Thank you, sir, Professor Mojumdar, for your nice talk. And may I now request Professor Prem Chand Singh to say a few words. Professor Prem Chand Singh, sir.
Good evening, good afternoon. I would like to thank Dr. Kamlesh Tiwari, President API, Dr. Mangesh Tiwaskar, Secretary General API, and all the dignitaries of the API West Bengal chapter for felicitating me on this Professor Siddhartha N. Shah Memorial Visions Day. I am deeply honored and humbled to be part of the Felicitation program, along with my respected teacher, Dr. Sukumar Mukherjee. Thank you very much. Thank you, API chapter, West Bengal branch. Thank you very much.
Thank you, sir. We really feel honored and grateful to you. Now we pass on to our next awardee. So here I already told you on the very outset of our program that for the first time we are celebrating two stalwarts of API. They are also esteemed and distinguished teachers. He taught us medicine, how to deal with patients and various other things. And both of them are very keen. Both of them were very keen to hear all the lectures very meticulously, used to put down the notes. And after each and every lecture, he used to say his statement and everything. So we all the time became enriched with presence of these two sorts of stalwarts of API, and they were very academic. So first of all, I will definitely love to say a few words about Dr. late Professor Arun Kumar Mojumdar. He will be felicitated for the first time in the history of API West Bengal chapter posthumously. And probably someone of them will be online. They couldn't come over here because of some technical problem or their busy schedule. They couldn't come over here. They were supposed to come over here, but they ultimately couldn't come. So may I request Professor Vibhuti Shah to come over here and to show online the offerings we are paying to our departed great soul of Professor Arun Kumar Mojumdar sir, and show online. Probably their relatives are watching all these things virtually. One shawl one certificate, and one medallion. Sweet box medallion. Their relatives were supposed to come over here, but they couldn't make it. Had they been over here, we would have been very much happy. And this is the medallion. Thank you, Professor Saha, for cooperating with us. Please have your seat. Now, I have been given chance by our API body to read out the Manpatra of Professor late Arun Kumar Majumdar. Professor Dr. Arun Kumar Majumdar was born on 30th November 1942 in the district of Howrah. He obtained his MBBS degree from Calcutta Medical College, Calcutta University, 1965, and MD in General Medicine from IPGMR, SSKM Hospital, Calcutta University, 1978. He was the Registrar in Medicine since 1979 to 1983. He joined the West Bengal Health Service in 1970, then West Bengal Medical Education Service in 1990. As lecturer in medicine, subsequently he worked as a faculty teacher in medicines in the capacity of assistant professor, reader, associate professor, and professor in different medical colleges of West Bengal for about 12 years. In his final promotions, he worked as professor and head of the Department of Medicine in Medical College, Kolkata, and Department of Medicine, IPGMR, and SSKM Hospital, Kolkata from 1998 to 2002. After his superannuation, he worked as professor at Mataguri Gujri Memorial Medical College from 2004 to 2006. In his teaching and academic career, he was one of the regular examiners in MBBS, MD in General Medicines, MD in Tropical Medicines, and in Calcutta University, University of Bardwan. He served as appraiser of General Medicine, Family Medicine, National Board of Examiners, Government of India. He was one of the very active life member of API, IACM, IMA, Diabetic Association of India, West Bengal, RSSDI, Academy of Immunotherapy of West Bengal, GSI, IAG, etc. He was also a fellow of IACM since 2006. He was life member of IAG and also GSI. He was awarded FICP by the Indian College of Physicians in 2016. He had more than 40 publications, both in national and international journals. He developed his interest in geriatrics in late 90s, and Professor Majumdar took an active interest in developing geriatric medicines in different medical colleges of Kolkata. And he regularly attended the national and international conferences of geriatrics and gerontology held in India for last 12 years. He completed a postgraduate certificate course of geriatric medicines organized by IMA, New Delhi, 2007 and 2008. He took part as a faculty teacher in UGC-sponsored State Conference of Geriatrics and Gerontological Studies in West Bengal in 2010. He was one of the founder member of Academy of Geriatrics in West Bengal, which has been included in as IAG recently. He worked as president of Academy of Geriatrics since its inception. His special interest in aging, immunity, and diabetology, he took part in the prestigious V.S. Natarajan Memorial Oration in the annual conference of IAG 2009. The topic was immunosenescence. Can we intervene? He had delivered Dr. Arun Banerjee Memorial Orations in IPGMR, Kolkata 2010, and his topic of discussion was aging, immunity, infections interface. Due to sudden demise of Professor Dr. Arun Kumar Majumdar on 2nd May 2021, API West Bengal chapter has lost a great academician, a perfect guide, and a great philosopher. The void is very difficult to be filled up. May Almighty grant eternal peace to this departed great soul. He is survived by his wife and 2 married daughters, and who are well established in their own field. Thank you. Now I request Professor Vibhuti Sir to say a few words.
Actually, I have seen many senior teachers in many meetings, but if I have to point out one who used to sit throughout the program, take note of whatever is happening and taking active participation, and in the way teaching us, everyone, that how to interpret a case, how to put questions, how to analyze a case, I think he is a person to be singled out. And this institute has been fortunate enough to have him as a member of, we have another society, Society of Tropical Medicine and Infectious Diseases of India, and he was also a member. And he was again a very strong source of inspiration for all of us. So with him, I think one legacy we have lost, but his memory should remain in the mind of all of us, who will be with us as a guiding star to teach younger generation how to analyze, how to be very analytical and critical. So with these few words, I pay my homage to the departed soul and my respects to sir. Thank you.
Is there anyone relative of late Professor Dr. Arun Kumar Majumdar online? Is there anyone, Pritam? কেউ আছে কি? ঢুকতে পারেননি? Oh. Then if they do come later, we will definitely allow him or her to say a few words about Professor Arun Kumar Majumdar. Now we pass on to our next awardee, late Professor Dr. Anup Kumar Bhattacharya, another stalwart of API. We have lost this person also in the early part of this year. And I would request Professor Sarkar to come over here. Professor M.K. Roy, sorry. I would request Professor M.K. Roy to come over here, to come on the dais. And please show online the offerings we are offering to relatives of Professor late Anup Kumar Bhattacharya as a token of our appreciations, regards, respect, everything. And his son has sent a video clipping. I would request I will request Pritam to start the video.
Good afternoon, everyone. I am Anirban. I am the son of late Dr. Anup Kumar Bhattacharya. I am extremely sorry for not being able to be physically present there today to collect the award on my father's behalf because of my classes. I would like to thank each and every member of the API Community West Bengal chapter and all the dignitaries who thought it fitting for my father to receive this award. Had my father been there with us today, he would have been humbled by this gesture. I would like to thank everyone on behalf of myself and my entire family. Thank you. Thanks a lot.
Thank you for your presence online. Now, may I request Professor M.K. Roy to read out the Manpatra of Professor Dr. Anup Kumar Bhattacharya.
Good evening, everybody. It's a proud moment, at the same time, very sad moment for me to read out the felicitation certificate of Professor Anup Kumar Bhattacharya posthumously. Now, the Association of Physicians of India West Bengal chapter felicitates Professor Dr. Anup Kumar Bhattacharya posthumously on Physicians' Day as Distinguished Physician and Master Teacher in recognition and appreciation for his outstanding contribution towards the medical education and ailing humanity. 23rd December 2021, signed by H.S. Pathak, Chairman API West Bengal Chapter, Dr. P.S. Karmakar, Honorary Secretary API West Bengal Chapter, Dr. Shivendu Gur, Scientific Chairman, API West Bengal chapter. Now, as usual, we always like to highlight the audience with a few words about the person whom we are going to felicitate. And in this context, this task has been assigned to me, and I have tried to collect the authenticated data about Dr. Professor late Anup Bhattacharya from various sources, and this has been also published in our Bengal Physicians Journal very lately. And actually I jotted down the important points. Dr. Anup Bhattacharya, MBBS, MD Neuromedicine, DM Neuro, MD General Medicine, FICP, FRCP Edin, FSCP USA, an eminent neurologist and astute physician, is no more amongst us. He passed away on the 18th of January 2021 for the heavenly abode. It becomes very difficult to speak coherently his versatile genius in accomplishing the immense contribution he had rendered in the field of medicine and his practice. He was an excellent academician, a student-friendly teacher, a dynamic person with extraordinary organizational capabilities, and above all, a human being bound to his moral values, ethics, patient care, etc. Being a person of such magnanimous stature, he was always down to earth towards his colleagues, friends, students, and patients. Younger of two sons of late Satyabrata Bhattacharya and Srimati Maya Bhattacharya, he was born at Digboy, Assam on 3rd December 1955. He formally completed his schooling at Amar Krishna Pathshala, Bhatpara in 1971. He had a brilliant academic career in his school days. During his early life, he used to play football. He liked reading storybooks, especially thrillers and adventures. He was a great music lover, especially Rabindra Sangeet. He spent 2 years in Siliguri and 2 years in Bhatpara during his early days before shifting to Noihati. He moved to Kalyani, Nadia in 2007. He passed MBBS from Arjikar Medical College, Kolkata in 1979, MD Medicine 1984, DM Neurology 1989 from IPGMR under University of Calcutta. He joined as a divisional medical officer in BR Singh Railway Hospital, Kolkata for some time in late 1980s. He worked as RMO-cum clinical tutor and then assistant professor in the Department of Neurology in Calcutta Medical College from 1992 to 1996. For a short period, he had been For a short period, he had been to London and had a clinical attachment to Queen Square Institute of Neurology, London. He left WB West Bengal Medical Education Service and joined an assistant professor of medicine in MGM Medical College, Kishanganj, Bihar in 1996, where he was promoted to professor of medicine in due course. He was in charge of neurology division in addition to his normal duties at the same institute till 2018. Subsequently, he left the college and joined as professor and head of the Department of Medicine in Agartala Government Medical College on 27 February 2019 and remained associated till his last breath. He was awarded the prize for various publications in neurology as well as in JAMA, and he was editor of journals of JAMA as well as he was editor of Bengal Physician Journal, and he had many other accolades to his credit. He was editor of also some other journals like West Bengal Bulletin Committee in 2012. He had delivered the prestigious G.S. Hainani orations under banner of ISEM, newly diagnosed epilepsy, what should I do? Beside this thing, he was the president of 105th Indian Science Congress Medical Section in 2018 and 17 and 18. He was a thesis guide and educator for MD General Medicine course and undergraduate and postgraduate examiner of different university. He took keen interest in various research projects. He was associated with a number of benevolent activities like epilepsy awareness, free health check camp in Noihati for last 20 years. He was associated with Student Health from Kolkata Nigamananda Ashram, Halishar, Noihati Municipality, Matrisadan, Shohid Khudiram Bosch Hospital, where he rendered yeoman service to the suffering people. He is survived by his wife, Mrs. Shashwati Bhattacharya, and an worthy son and a daughter who are accomplished in their own fields. His passing away has created an irreparable vacuity, which is very difficult to be filled up. We will miss a true human being par excellence, whose philosophy of life and humanism made him a unique person who will be an abiding source of inspiration for future generations. Man is mortal, but the soul is eternal. The spiritual tenet of a person can never be destroyed. It's invincible. Though we mourn his bodily absence, his indomitable spirit shall live on in our collective consciousness for years to come. With these few words, I hereby conclude and pay my best regards and homage to the departed soul. Thank you very much.
Thank you, sir. Please have your seat over there. Professor Roy, sir, please have your seat over there. So now we'll pass on to our next stalwart of API, and he is one of the best teachers in his time. He is none other than Professor Kiranmay Mitra. We have learned a lot from him, so far medicine is concerned. So we really pay our regards, respect, and all sorts of love for him. And I would request Dr. Soumitra Ghosh to escort Professor Kiranmay Mitra to take him to the task. And I will request Professor D.K. Majumdar, Professor Vibhuti Saha, and Professor M.K. Roy to felicitate Sir. May I request Professor Soumitra Ghosh to read out the short CV of Professor Kiranmay Mitra.
No, Professor Kiranmay Mitra was born in the year 1940 in Kolkata and had his schooling in Jamalpur High School in Bardhaman. Professor Dr. Kiranmay Mitra graduated from Arjikar Medical College, Kolkata in 1965. He earned his MD in General Medicine from University of Kolkata in 1978. He has served in Uluberia, Jalpaiguri, Chandannagar hospitals. After serving West Bengal Health Service, he joined West Bengal Medical Education Service in 1990. As a medical teacher, he has served Kolkata National Medical College and later Bardhaman Medical College as head of the department. He retired from WBMES from Arjikar Medical College as Professor of Medicine. He is a life member of API and has been the executive committee member of the West Bengal branch for 2 terms. He is a fellow of the Indian College of Physicians. He is a very sincere and hardworking physician and is remembered by his patients and remembered by his students. A physician of excellence and a doctor like him is always an inspiration for the future generation. API West Bengal branch wishes him a very active and long life. May he continue to serve the suffering humanity with his knowledge and sincerity. We pray to God for his long life. Sir.
May I request Professor Kiranmoy Mitra to say a few words? Professor Mitra, sir.
Good afternoon, everybody, and respected dignitaries of the West Bengal. Today I have come here for a special occasions as West Bengal API of West Bengal branch felicitating me. I thanks to the executive members of the West Bengal Medical College for this facilitation. I had accounted with the API from 1980, and then I have got 2 terms in executive members. I thank you all members of the executive member of the API, long leg API. Thanking you all.
Thank you, sir. Now we pass on to our next awardee, that is Dr. Govindo Das. But for some reason, he couldn't make it to come over here. So I will request Dr. H.S. Pathak to come over the dais. And please, Dr. Pathak, sir, please come over the dais and show the offerings we are paying. Show the offerings we are paying. To show all the offerings online of Professor Dr. Govindo Das. Oh, it has already been. So, okay, it has already been offered. So please show the clippings of the photography. Still photography is there, no? Not video, but still photographies are there. He is showing that. And I would request Professor Dr. H.S. Pathak to read out his short CV. Yes.
Professor Govindo Chandra Das passed his MBBS and MD from NRS Medical College and was first posted at very now known place Nandigram Primary Health Center. He worked in several peripheral hospitals including Krishnanagar, and my interaction with him was around 1979-80 when Professor Das was RMO in the Department of Cardiology and I was a house physician. And at that time, he used to give suggestions and some form of teaching to all aspiring postgraduate students. He was head of the Department of Cardiology in Calcutta National Medical College and also President of Cardiological Society of India, West Bengal. Professor Das has published several scientific papers in national and international journals. He also attended Asian Cardiology Conference that was held in Seoul as faculty and presented a paper on TR ventricular dilated cardiomyopathy. Professor Das also attended the World Cardiological Conference, which was held in Berlin as faculty and presented a paper on hypertrophic cardiomyopathy on ventricular arrhythmia. He is a man of substance and has profound knowledge in his professional field. Having a brilliant academic record, he continues to bring to our medical fraternity and guides his patients with his benevolent efforts. He is a very sincere and hard-working physician and is respected by his patients. A physician and a doctor like him is always an inspiration for the future generation. API West Bengal branch wishes him a very active long life. May he continue to serve the suffering humanity with knowledge and sincerity. We pray to God for his long life. Thank you.
Thank you, sir, Professor Pathak. Now we come to another very senior, active API member. He has come all the way from Bardhaman over here to attend this felicitation program. And I would request Professor R.N. Sarkar and others to escort Dr. Ashish Ranjan Banerjee. Please have your seat. And I would request Professor Sarkar along with Professor D.K. Mujumdar, Professor Vibhuti Saha, and you also, sir. You also have joined in celebrating Dr. Ashish Ranjan Banerjee. Sir, please stand over here. Now, may I request Professor R.N. Sarkar to read out curriculum vitae of Dr. Ashish Ranjan Banerjee. We are very pleased and honored that he has come all the way from Bardhaman to here. Professor R.N. Sarkar, please.
It's my proud privilege. এটা তো দেওয়া ছিল আগেই, দেওয়া হয়ে গেছে তো না, এখানে লেখা আছে to felicitate Dr. Ashish Ranjan Banerjee, who is a doyen physician of Bardhaman. He was born in 1934. He passed school final from Bardhaman Town School in 1949 and ISc from Raj College in 1951. Then he passed MBBS from National Medical College in 1956. He obtained MSc degree from Edinburgh in 1967 and from London in 1968. He was awarded ICMR Junior Rockefeller Scholarship and posted as a in Lucknow KJMC at that time for 2 years. He joined as SHO in chest medicine in Lodgemore Hospital in Sheffield for 6 months and then proceeded for an attachment in City General Hospital, Edinburgh, under Professor John Crofton, famous chest physician, for 5 months. After returning to India, he first worked in Durgapur Still Hospital, and since then he's practicing as consultant physician in Bardhaman. He is a brilliant student, and he was a brilliant student, and now he's a eminent clinician and humanitarian. And this is a brief CV of our Ashish Ranjan Banerjee.
Thank you, Professor Sarkar, for your cooperation. Now, there are some API senior members who are really doing marvelous job in their peripheries in the district, not in Kolkata. So we had to take care of all those senior actively participating in API activities. We had to felicitate them. So after this, I would request Dr. Tapas Banerjee to come over the dais and for the proceeding of the rest of the physicians' felicitation. Please come over here. Before Dr. Tapas Banerjee starts his proceedings, I would request Dr. Ashish Ranjan Banerjee sir to say a few words to us. Sir, please.
I'm very glad that West Bengal chapter API feliciting me, and I am 89. I have consultant physician practice for the last 52 years at Bardwan. Since 1969, I remember 1989 when I was attending the API conference. Professor Sukumar Mukherjee was the organizing secretary, and cardiologist Dr. A.B. Mehta of Bombay, API president. Now, on the dais, Chief Minister Jyoti Basu was by the side of A.B. Mehta. Now, when A.B. Mehta start his lecture, now he was humorous enough that the short height. Now I am audible, but I am not sure I am not visible. Now that Chief Minister Jyoti Basu was seldom smile. He has got a Parkinsonian face. Now, to my surprise, Dr. A.B. Mehta was told in his lecture, now it was a thrilling experience of by this side of sitting for hour by the side of famous Chief Minister Mr. Jyoti Basu. But he was telling that once the thrilling experience of my life, when I was sitting by my wife, but her name was also Jyoti. Now, see, Mr. Jyoti Basu was seldom smiling, but he was laughing. Now, I don't know Dr. A.B. Mehta his health, whether he was surviving or not. But I was still remember his face, his lecture. Now, Thank you very much for felicitating me. I was elated. Thank you very much.
Thank you, Dr. Ashish Ranjan Banerjee. You please bless us, all of us, to be physically active, mentally alert at the age of 89 years. We are really feel honored that we have got within ourselves a person like you who is at the age of 89 years, and that courage he does have to come over here to attend the felicitation. We are really thankful, and hats off to your venture, sir. Thank you, sir. Now I hand over the mic to Dr. Tapos Banerjee for rest of the proceedings.
So thank you, Dr. Karmakar. Now we'll start felicitating our senior members of API West Bengal branch. And the names are from Mednapur, Dr. Divakar Samanto; from Murshidabad, Dr. Srikanto Chatterjee. It is no more. And Dr. Somesh Banerjee, Dr. Devashish Ghosh, Dr. Vishwadip Agarwal from Malda, and from Siliguri, Dr. Indrajit Banerjee and Dr. Kallol Dasgupta. Oh, okay, I understand. So may I read out the? Yes. So this is the first one. Okay. I got. So this is Dr. Vishwadip Agarwala from Malda. Yes. This is Dr. Divakar Samanto. We feel proud to felicitate Dr. Samanto from Midnapur. And this is his CV. Next is Dr. Somesh Prasad Banerjee. He is from Murshidabad. We are privileged to felicitate Dr. Somesh Prasad Banerjee. This is his CV. Next is Dr. Devashish Ghosh. Proud to felicitate. The West Bengal branch is proud to felicitate Dr. Devashish Ghosh from Murshidabad. Next is Dr. Srikanto Chatterjee. Unfortunately, he is no more. It is posthumous felicitation award. Felicitation. We are privileged to felicitate Dr. Srikanto Chatterjee. And from Siliguri, we have two dignitaries, very senior members for felicitation, Dr. Kallol Dasgupta and Dr. Indrajit Chatterjee. They will be felicitated by Siliguri City Branch at a later date as per information. So this is all about felicitating the senior members from the district. I am privileged to present the respected dignitaries and thanks our President, West Bengal branch, and the Secretary for giving me this opportunity to read out their CV. Thank you very much.
Now, all good things must come to an end, and we have come to almost the end of our program, but please sit down. The most important part is still left, last but not the least, that is vote of thanks. And I would request Dr. M.K. Roy, please come on the dais and please offer vote of thanks on behalf of API West Bengal chapter.
Professor M.K. Roy, please. Just for 2 minutes, it's our duty to offer customarily the vote of thanks on behalf of API West Bengal chapter on this Physician Day, the auspicious day which we have just observed. At the very outset, I like to extend my heartfelt thanks. Please, just a minute, beer, please. Just 1 minute. Don't laugh. Please, 1 minute. I extend my heartfelt thanks to Professor Kamalesh Tiwari, our president, who is on virtual line, and Mangesh Tiwashkar, who is the Secretary General of API headquarters, and Professor Dr. Amol Banerjee, who is the chairman of API Forum, ICP Forum chapter, chairman of API ICP Forum chapter, who is online, and other dignitaries who are over here presently, they are not here. The Vice Chancellor, the Director of this institute, and the head of the department, as well as our Principal of Medical College, Dr. Manju Banerjee, our respected Chairman, sir, that is our Harishadan Pathak, and respected dignitaries and all the persons who have been felicitated today, starting from Professor Sukumar Banerjee, Ashish Basu, Dr. Kiranmoy Mitra, and others who are present today, and those who have been given the posthumously. So it is our honors that we should extend our heartfelt thanks for your kind cooperations, your presence on online and offline, and all the delegates who are there throughout the whole entire program and has given us the encouragement for a successful outcome. I will be failing in my duties if I do not extend my heartfelt thanks to the School of Tropical Medicine, especially the Director of School of Medicine, and also Dr. Vibhuti Shah, Professor Vibhuti Shah, who is a part and parcel of our API, and he has done a beautiful job for us. And I am really grateful to all the members of their team and staff. As well as I will give my thanks to the Cubics who have given us the assistance for this audiovisual program and all the electricity supply during this whole period, and other people who are directly and indirectly involved to make this program successful. With these few words, I again extend my heartfelt thanks from the core of my heart to make this program again success. Thank you very much.
Only one group photo, all of us. Group photo. Please come with mask on. Please come with mask on. I'm secretary, ICB secretary. There will be two photos. One mask on, mask off. Group photo. দুটো লেভেলে করতে হবে বলে সামনে বসে আর একটা দাঁড়িয়ে তাহলে ফটো কোয়ালিটিটা ভালো হবে এই পেছনে চেয়ারে বসেই চলবে নন্দিনী এডুকেট করছে আমি বড় না আমি ছোট বুঝতে পারছি এবার মাস্ক অফ নাকি হ্যাঁ মাস্ক অফ করুন মানে এটা অপশনাল যেটা বলছে স্যার তাড়াতাড়ি করো না এটা কোনটা থ্যাংক ইউ
এটা বন্ধ করো আগে, এটা আগে বন্ধ করো, এটা আগে বন্ধ করো, লিফট করে দিচ্ছি, লিফট করে দিচ্ছি, হ্যাঁ লিফট অফ করে দাও।
আরে তো ব্যাট তো দেবে না ভাইয়া। হ্যাঁ হ্যাঁ আছি।